Good morning, everyone. It's a great honor to be here and to have the opportunity to present my PhD topic entitled Current Management of Endometrial Cancer. My name is István Madár. I'm a PhD student and an obstetrician and gynecologist at the Semmelweis University. We believe that every endometrial cancer patient's life quality and length can be improved using novel methods. So this is the reason why our mission is to improve the management of endometrial cancer patients by applying up-to-date scientific results. In order to fulfill our mission, we set up two major projects. In the first project, we compared the transvaginal ultrasound and magnetic resonance imaging in the preoperative stratification of endometrial cancer. And in our second project, we are doing a systematic review and meta-analysis on the systemic therapy for recurrent and advanced endometrial cancer. So let's see my first project. About the pivotal role to talk about endometrial cancer, my colleague has already spoken, but I have to highlight once again that this is the most common gynecological cancer, being one of the leading causes of death among women's cancers. A proper preoperative stratification, specifically the assessment of myometrial infiltration, will result in reduced unnecessarily extended surgeries. The most common techniques for this is the transvaginal ultrasound and the magnetic resonance imaging. I have to highlight, however, that in case of low-grade endometrial cancer patients where fertility sparing comes into question, the question of the method of choice remains unclear. So our clinical question was whether transvaginal ultrasound has similar performance as magnetic resonance imaging in preoperative myometrial infiltration assessment. And we hypothesized that indeed transvaginal ultrasound provides similar performance as magnetic resonance imaging. And this, so the clinical implication of our work would be a reduction of costs and complications of the unnecessarily extended operations. So after conducting our systemic research, 18 articles provided to be eligible for the final analysis. And here we are a brief summary of our results of the first project. So you can see that in case of, so both transvaginal ultrasound and MRI provides similar sensitivity and specificity without statistically significant difference between the two methods. However, in case of low-grade endometrial cancer subgroup, magnetic resonance imaging provides significantly better specificity. As any other meta-analysis, our study has strengths and limitations. The case number is really a strength of our study. And I have to highlight that we have included only those patients who had undergone both transvaginal ultrasound and magnetic resonance imaging prior to operation. We have to remark that in case of low-grade endometrial cancers, however, more cases are needed, and obviously the results might be influenced by the different scanning protocols. Translated to clinical meaning, our study would highlight that transvaginal ultrasound can be the first choice in the preoperative assessment, and in case of low-grade endometrial cancer patients, besides transvaginal ultrasound, magnetic resonance imaging is justified as well, especially in case of fertility preservation thoughts. So actually our article is submitted to our journal, a Q1 journal. And let's move on to my second topic, in which we investigated the role of systemic therapies in the recurrent or advanced endometrial cancers beyond the cytotoxic protocols. About the pivotal role of the endometrial cancer nowadays, I have already spoken. I have to highlight, however, that the incidence and the mortality are rising worldwide, and almost 1 out of 5 patients will have recurrent disease. And unfortunately, there is no standard care for second-line systemic therapies. What can we do then? Actually, we can obtain for local surgical therapy, or we can do a systemic therapy, which can include hormonal therapy, cytotoxic therapy, or emerging role of the target therapies. So our question was whether combined therapy protocols offer better survival than single-agent protocols, and we hypothesized that combined therapy protocols will indeed offer better survival rate. We have done our systemic search in 3 major databases, obtaining in the end 109 articles. And you can see on the first result that the progression-free survival, which will be better for the combined therapy protocol. However, the difference is not statistically significant. Due to the fact that I have a tremendous amount of forest plots, I will present you only the progression-free survival at 12 months, so at 1 year at each analysis. If we take a look on the bevacizumab-containing chemotherapies, we can see that more than 40% of patients will reach 1 year progression-free survival. If we combine bevacizumab with cytotoxic chemotherapy, we see an increase in the survival rate of the patients. If we take a look on the mammalian target of rapamycin inhibitor pooled forest plot, we can see that unfortunately less than 20% of the patients will survive progression-free for 12 months. If we combine, however, these inhibitors with aromatase inhibitors, there is an increase in the survival rate, in the progression-free survival rate. In case of PD-L1 inhibitors, you can see that almost half of the patients included in this study will survive until the 12 months. So there are the hormonal therapies which are yet to come to our result pool. And finally, approaching the end of my presentation, I would like to show you once again our aims. And in the end, I would like to thank you for your kind attention.
So in your clinical practice, what do you use as a chemotherapy?
So first of all, we use chemotherapy paclitaxel carboplatin, and if there is no progression, so no result, significant result, then we will use the targeted therapies. So in our daily practice, the usage of targeted therapies is becoming.
Do you have any kind of experience about this? Targeted therapies?
Actually, we don't have a register yet. We are collecting the data because this is, so we have begun using targeted therapies for not so long time ago. So we are collecting the results, and hopefully we will have within a couple of years results to be presented.
Okay, thank you.
I have 2 questions. The one is to the statistics for your second study. You use as an endpoint the 12-month progression-free or overall survival, but it is mostly not used with a cutoff, just overall survival, time to event endpoint. Why did you decide to use the cutoff for 12 months?
Actually, I had data from the most of the studies for 6, 12, and 18 months. But due to the abundance of data I had to present, I have chosen to present you the 12 months data. Usually, it really illustrates really good the overall tendency of the progression-free survival.
Okay, so this is only one of your endpoints, and you also
Yes.
analyze it without a cutoff, or just with a cutoff?
We did it without cutoff as
Okay.
well. So it was an arbitrary choice of mine, of our team, to present this, but we have data for the 6 months, 12 months, and 18 months as well.
Okay. And the second question is, you were speaking about targeted therapies, and we know that targeted therapies are mostly effective in subgroups of patients. So are there any pre-selections on the histology or molecular background, mutational basis to opt for one or another targeted treatment?
So, broadly spoken, in case of targeted therapies, the mismatch repair deficient groups are the best target groups, and the mismatch repair proficient ones are not the best group for targeted therapies, especially for the PDL inhibitors. So, in most of our studies, there is a mixed group. Yes. There are a couple of studies with subgroup analysis, including exclusively mismatch repair deficient analysis, but most of the studies includes, unfortunately, a mixture of deficient and proficient group.
Okay.
Which may have an implication on the results, obviously.
Yeah. Do you plan to try to perform a subgroup analysis if these molecular data are available for each study? So that would be really interesting to do.
Yes, we intend to perform a subgroup analysis, and actually I'm thinking of rerun the search because this is a really skyrocketing piece of oncology. And new articles are coming day by day. So actually, I'm sure that I will get a couple of new articles if I rerun the article, even if we are within 1 year after my initial search.
And you said that you already use targeted therapies in your clinical practice. So are there any pathological markers that you are already using in the practice, or you just opt one of them by chance, or how do you decide for?
It's a really good question. Actually, we use the available targeted therapies, and obviously the judgment is made by an oncological team, especially taking into consideration the molecular subtypes. Yes.
Okay, so you are already use it.
Yes, we use it.
Tumor boards.
Yes, with the tumor boards.
Okay, thank you very much.